Hi everybody, I'm Dr. Melton. If you have not met me before, I do the bariatric procedures here at Colquitt Regional Medical Center. I'll tell you before we get started, I talk very plainly to people. I don't believe in beating around the bush and pussyfooting around topics. I know what it means to have a weight problem. I've struggled with it my entire life. I've got a sister and I have a brother and 3 sisters, and it's only in the last couple of years that I'm not the smallest one in the group. My oldest sister actually has lost a good bit of weight, but until then I was the smallest one in the crowd, so I know what it means to struggle with your weight. Consequently, I know sometimes when you're feeding me a line, and I tend to call people on that. I'm not trying to offend anybody, but I'm going to tell you straight up what I think. What we're going to do tonight is we're going to learn something about lap bands and about different options available to you, okay? You've all heard the old saying that knowledge is power. Well, the same thing applies today as it did years ago. You've got to know what it is you're getting into to make a good informed decision about whether it's appropriate for you and then to get the most out of it. Okay, so with that being said, can everybody see the screen? Okay, not because you need to see him. This is me. I've been doing lap bands here since 2008. I did do them for a year over at Smith Northview in Valdosta, but that program closed down. We don't do them over there anymore. Now we have folks coming over here from Valdosta. So we've been doing them for approaching 4 years and have been doing this seminar for a little more than 4 years. In that time, we've kind of been through it enough that I think we're going to hit your questions pretty well. If you have a question during a seminar, this is going to be very informal. Raise your hand, throw up a flare, whatever, get my attention, and we'll answer your question, okay? We will save some time at the end for more question and answer. The rest of our bariatric team, and the name of the facility is the Bariatric Center at Colquitt Regional Medical Center. Bariatric means related to obesity. Bariatric surgery is obesity-related surgery. Nicole and Ashley are sitting back in the back. They kind of run the Bariatric Center and the support group, which we'll talk about in a little bit. Wendy Brown is in our dietary department. She does pre-op dietary evaluations and counseling, and then after surgery as well if we need her to. Margaret McDaniel is a licensed clinical social worker. She is here in town. She does our psychological evaluations and is also available after surgery if we need her to do psychological counseling at that point. Laura Griffin runs the second floor, which is where most of our patients go. She is one of the nurses, and her team of nurses take care of you after the surgery and then get you up and going and usually home the same day. Okay? That phone number that you see at the bottom of the screen is the phone number for the Bariatric Center. Feel free to call. You can talk to Nicole or Ashley, or you can call my office, and my number's in your packet also, and talk to anybody in my office if you have a question. Okay? People that we don't list in our team, we have a large group of our primary care physicians in town that are interested, have a definite interest in weight management, and have gone so far as to go through training programs with Allergan, the company that makes the lap band, in order to help with postoperative care. And they have started doing that now. In particular, Dr. Schwartzentruber, Dr. Baker, Dr. Treboni, Dr. Kirby Smith and Chris Basil are going for that training with Allergan shortly. Okay? So it's not just me. And our plan is that we set up a freestanding building where you would go to one place and do everything at one time. We're not to that point yet. You'll be coming to my office and their offices and the bariatric center over at the marketing department, that kind of thing. But all of that is probably going to change within the next year. All right, what are we going to talk about tonight? We're going to talk about obesity, trends and impacts. What does it mean to you? How does it affect your life? We're going to talk about options to treat obesity, including surgical options and non-surgical options. We're going to talk about why we do the lap band. Notice on the screen, lap band has that registered trademark sign. The name of this procedure is actually laparoscopic adjustable gastric banding. The lap band is a trademark name for a device that's made by a particular company called Allergan. They have been making this device now for 17 to 18 years worldwide, and it's been available in the United States now for 11 or 12 years. Hundreds of thousands of them have been done. There is another band on the market that is available. It is available in Tallahassee. We do not use it. It's made by a company called Ethicon. There's not anything particularly wrong with it, but some new studies do show that the Allergan product works better and has fewer side effects, fewer complications. I think it's a superior product. It's been around longer. It's on its 4th generation. They've got all the bells and whistles. They've got all the kinks out of it, so to speak. It's like buying a car that's been redone 3 times. They figured out what worked and what didn't work, and so they've improved it. But we're going to talk about the lap band. We're going to talk about risk and benefits because, folks, there ain't no such thing as a free ride. Okay? Everything you do has risk. There is some risk in you getting in your car and driving home when you leave the seminar tonight. Now, I hope everybody makes it home just fine, and most likely you will. But there is risk involved in doing that. I'm going to show you some patient profiles, some people that are provided by the company and some of ours. We're going to talk about why the lap band is a good choice, and in particular, why using the lap band properly helps you lose the excess weight, the fat, without sacrificing muscle and bone and tendon and the good stuff that you want to keep, which losing weight too quickly can do. We're going to talk about what it costs to be overweight versus what it costs to have an operation. Because again, like we said, there ain't no free ride. Okay? And then we'll show you some things about support and resources available to you. All right? So, what are we going to talk about? We're going to talk about body mass index. Okay? Body mass index, or BMI, is a relationship of your height to your weight. If you don't know your BMI, and if everybody weighed in with Nicole when you got here, you do know your BMI. But it's available in 5,000 different BMI calculators on the internet. Or if you have a phone, you can download it on a smartphone and you can check it anytime you want to. You can go to lapband.com where they have a BMI calculator. Again, with a smartphone, you can download a new app that they have out called Lapband Mobile that ties to my Lapband personal journey, and we'll talk about the personal journey in a little bit. In particular, with BMI, we're going to concentrate on this box out here. Above 30, in particular, depending on your insurance carrier, it may be 35 to 40 if you have comorbidities or things like diabetes, high cholesterol, high blood pressure, heart disease, etc. Even though the FDA current recommendation, that's been that way for 15, 16 months now, is a BMI of 30 with any of those problems. Most of the insurance companies have not come on board with that. I really expected them to in January, and they haven't yet. But a BMI of 30 to 35 or higher with one of those medical problems, or a BMI above 40 with no medical problems. If you're that person, I'll be very surprised. I don't think I've seen someone with a BMI of 40 that didn't have a medical condition that we could find. But that's what we're going to concentrate on. And again, it's a relationship of your height to your weight. For example, you look at your weight in pounds over here and your height in feet and inches over here. Some of them are set up in kilograms and centimeters or inches or whatever. But you take your height and come across to your weight, and there's your BMI. So we're looking for people that are from this line up to the corner on this one, above 30. In the past, we looked at obesity as a weakness. There was a failure on your part. You didn't have enough self-control or willpower or whatever you want to call it. Diet and exercise were the prescribed treatments. Anybody ever been told to eat less and exercise more? Yeah, that's very, very common. How'd it work for you? Not so hot, right? Weight loss surgery was viewed as extreme. You were really stepping outside the box. It has always been and still is an acceptable form of social discrimination. Have to pay for 2 airplane seats or 2 bus tickets, or if you go to a new restaurant, are the tables closer together or further apart with bigger chairs? Which one is it? No, everything is smaller and crammed in there, and you want to get one more chair on the end of the row at the movie theater. All of that comes down to dollars. Okay, if GM could cut 1 inch off of the webbing that they used to make seatbelts with, and they did that in every seatbelt in every car they made, how much money would they save in a year? Well, it would be significant. So they've done that several times. So some people have to buy an extender to be able to fasten their seatbelt. These are common forms of social discrimination that you can see if you just look around you today. Now, we don't look at obesity the same way. We look at obesity as a disease with significant health risks. We're going to go over some of those. Diet and exercise remain a cornerstone of treatment. You have to pay attention to what you eat. You have to be active. We want everybody to start going to the Y, or to work out on the bike trail, or to walk around your living room, or whatever it takes to get you moving. But diet and exercise still have to be a mainstay in the treatment. A lap band can be very helpful in that, but folks, it's not magic. It is not magic. You are still responsible for what goes in your pie hole. Okay? Now, I say that jokingly, and people laugh about it, but it's true. You are responsible for what goes in your mouth. You can stop at any fast food place on the way home and get the extra large double chocolate milkshake, and it will go right through a lap band every time. It will not slow down. Okay? The lap band will not stop you from drinking those drinks or eating cake and pie and ice cream. It won't do it. It's incapable of doing that. It is a tool for you to use. It is not magic. It is one tool in your toolbox for you to open up to use to manage your weight. You still are responsible for what you eat. You still are responsible for an exercise program, and you can defeat this device if you so choose. Okay? It is not magic and automatic. People sometimes are disappointed when they hear me say that, because everybody wants the magic bullet. I'm sorry, folks, that doesn't exist. However, when you approach it properly, and when you use the lap band as intended as a tool, it can be very, very helpful in you managing your weight, getting the excess weight off, and being healthier. Okay. Surgical treatment is appropriate for qualified patients. That doesn't have anything to do with your insurance. If at any point during this process, if I or anybody else on the team thinks that you're not an appropriate candidate, either it may be something very clinical, like you have heart disease that means you shouldn't be put to sleep. Well, okay, that one's easy. But if we think that for whatever reason you're not going to use this properly, that you're not investing your entire future in doing this, that you don't understand it's going to be a lifelong commitment, if we don't think you're going to use it correctly, then you're not going to have one. You're not going to have one here. You can go to Mexico and get one, or somewhere else, and somebody will put one in you. It doesn't mean you can't have one. It just means you can't have one here. Okay? I don't expect that to be a problem. It is uncommon that we have somebody that we pick that up on. But I always tell folks that. If I don't think it's appropriate for you, if I think you need to look at a different option or do something else, I'll tell you that. Okay? All right, bariatric surgery is a proven weight loss method. No question. It works. We're going to show you some of that. Why are we doing this? Because we're not getting smaller, folks. We're getting bigger. Over 72 million people in the United States are obese, above a BMI of 30. 23 million people with type 2 diabetes. 85% of people with diabetes are overweight. Okay? According to the CDC, 53% of obese adults in the United States, and this is 5 years old, were diabetic. Are we getting smaller as a society, or are we getting bigger? Why did New York recently come out and ban Biggie size? They won't let you buy that triple size soft drink at the movie theater, or you can't do that anymore. This is why. If you look at Georgia, down in 2008, we were right here, just below 30%. The most recent data now is that the population in our state is that 33% of us are considered clinically obese. We have a BMI of 30 or above. 33%, 1 in 3. You see it all over the place. You see it on magazines and movies, and the Super Size Me, the guy that ate nothing but McDonald's fast food for a month and almost wound up in an intensive care unit. Wall Street Journal, other wonderful medical publications like Ladies' Home Journal and stuff like that. There's always something in there about diet and how we eat and how we should be eating, but it doesn't seem to be sinking in, because the next page is an ad for the new double extra large Whopper with cheese and bacon and I don't know what else. There's always something, and they hit you from both sides. And we already established that we don't have good willpower, so we go get them. And when we do, our risk of developing all kinds of medical problems goes up. Okay? Your chance of developing diabetes over the next 10 years, and this is in men with a BMI of 35 or above, is 23%. When you move that up to 40, your risk goes up to 49%. 49%. Almost 50-50 chance you're going to get diabetes. Very scary. Okay? Risk factors when you are obese. Diabetes, heart disease, high cholesterol, all kinds of problems, including cancers. This is one we didn't know about until just a very few years ago. Breast cancer, colon cancer, endometrial cancer, kidney cancer, liver, pancreas, lung. The list goes on and on. These things are related to obesity. Infertility is related to obesity. Okay? Asthma, pregnancy problems. There's a long list. It's kind of like that commercial on TV with the side effects of drugs, right? We don't want to actually read them all out loud. But the point is, when you treat the obesity, you treat all of these problems. They all get better, and a lot of them go away completely. A high percentage. It's remarkable. Actually, I'm going to show you another slide in a minute. What does it cost? Well, this next couple of slides, or several slides in the deck here, show you that it costs you money to be overweight. Because when you're overweight, you have more health problems. We just established that, right? When you have more health problems, you have to access health care more frequently, and you have to have more things done. So you wind up with knee joint replacements and hip surgery and back surgery, and you have diabetes, and you're on a bunch of medicines, and all of these things add up, and none of them are free, because we established very early tonight that there is no free ride, right? So you may have insurance that pays for all of these things, but someone is paying for it. Either you or our government or society in general is paying for health care. So if you take a proton pump inhibitor like Nexium for reflux, that's about $140 a month. Diabetes medicines, anywhere from $75 to $300 a month each. High blood pressure medicines, $50 to $150 a month each. Cholesterol medicines, $100 to $300 a month each. Very, very quickly, you can run up $800 to $1,000 a month in medicines. Very, very quickly. Okay? So there are such things as weight-related medical costs. It costs you more money when you're overweight. Okay? The good thing about losing that weight is that you can recoup a good bit of those losses. 99% of the money that you spend getting a lap band, you can recover within 10 years. If you're diabetic, it's a lot quicker than that. 4 years and 3 months. That's if you pay cash for it. And that was based on their costs, their prices, not even what our current prices are. So very, very quickly, you pay for this procedure. If you don't have insurance and you're paying cash, you pay for this procedure very quickly just in getting off some of those medicines. Okay? Plus it's tax deductible. Talk to your accountant about that. Medical costs are deductible. All right, how are we going to treat obesity? We talk about something called excess weight loss, meaning the amount of weight above your quote-unquote ideal body weight. All right, if you're supposed to weigh 130 pounds and you weigh 230 pounds, then you have 100 pounds excess body weight. Simple, right? Okay. Sometimes we'll talk about losing that amount of weight, or sometimes as a percentage of that amount. If you're 200 pounds overweight, and we say you're going to lose 50% excess body weight, that's 100 pounds. Okay? So anyway, just think about that when you're looking at what you can reasonably expect to lose with different options that are available to you. All right? All right, so how do we lose weight? Different strategies for losing weight, right? We already talked about diets. There's the D word, okay? We talked about going on a diet. Dieting's not that hard. We can lose weight, right? I can lose weight. I can drop 15, 20 pounds without any trouble. The problem is maintaining that. And over time, what we tend to do is lose a little weight, and then you tend to get your weight come off the wagon, so to speak. You come off your diet, you quit going to the gym, whatever, and you gain your weight back plus 3 to 5%. And then the next fad diet comes along, like the cabbage soup diet, or the next craze with Atkins, or the HCG diet, or any of those kind of things. And well, okay, I'm going to try that one. That's going to be the ticket. That one will work. And then you lose weight, and then you tend to plateau and come off that diet because diets are very hard to maintain. And then you tend to gain your weight back plus 3 to 5%. So over time, you watch your weight slowly creep upwards. Does that sound familiar to anyone? Yeah. Very, 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 very common. We've been told to eat less and exercise more, and that includes your doctors think the same thing. One of my partners has no interest whatsoever in doing this procedure. He says, you shouldn't be doing that operation on people. They just need to eat less and go to the bike trail. He's never been a fat boy. He does not understand. He still runs marathons and wears the same breeches he had in high school. Some folks, it is just not that simple. So we can lose weight, but maintaining that weight loss is very difficult. Physical activity alone in someone with a BMI above 40 has never been shown in one study to work long term. Because what happens when you have a BMI of 40 and above and you go to the gym and start working out? Get on the exercise bike or the elliptical, or you start lifting weights, or you're doing aerobics or step or jumping in and out of the pool or whatever it is. Pretty soon, your ankles hurt, your knees hurt, your butt hurts, your hips hurt, your back hurts, your neck hurts, you can't move your shoulders, you can't get up and go to work, and you quit going to the gym, and then you gain your weight back plus 3 to 5%. Again, sound familiar? Very, very common. Behavior modification can be helpful. People do all kinds of things. They go get acupuncture and they burn incense and chant and meditate and do hypnotherapy, and there's all kinds of things. I even think Weight Watchers is a form of behavior modification, and it works. Weight Watchers works. By their data, you can expect to lose 8 to 10% excess body weight and maintain that. Well, how much is that? If you are 230 pounds and your ideal weight is 130 pounds and you are 100 pounds overweight, if you expect to lose 10% excess body weight, how much is that? 10 pounds. So now instead of weighing 230 pounds, you weigh 220 pounds. Well, yay, Rod, good for you, but you hadn't lost a whole lot of weight. The reason I talk about Weight Watchers with behavior modification, and it is successful, is how do you do Weight Watchers? You go to a meeting, you walk up in front of everybody in the room and get on the scales. And they say, yay, Susie lost 4 pounds this week. Everybody claps, right? Susie goes back and sits down, comes back the next week. Susie didn't lose any weight this week. And they say, well, Susie's going to do better next week. She'll be back and she's going to lose weight. She's going to try harder. Susie comes back the next week and she's gained her 4 pounds back. Uh-oh. Susie don't go back to Weight Watchers. Okay? The reason people lose that weight that they do is you have to stand up in front of everybody. It's peer pressure. It's the punitive effect of not losing weight. So it does work to some extent and can be very helpful for a lot of people. Who is it on TV? Jennifer Hudson? Wasn't she with Weight Watchers? Lost a ton of weight. Looks wonderful. But, you know, the little disclaimer at the bottom, these results are not typical. Your results may vary. Okay. Drug treatment for weight loss can also be very helpful. It has to be used really as a jump start. Things like phentermine and Xenical, and there are a couple of new ones that are coming out that were just released this week, as a matter of fact. But these are helpful in the short term only. If you have high blood pressure or heart disease, strokes, carotid vascular disease, whatever, you can't take these medicines because they can kill you. They can make you have a stroke. So you have to be very careful with the medicines. You can only take them a short period of time. And they do run your metabolism up, which helps you lose weight. But the problem is you can't stay on very long, and then you eat like you always have. It's just you've lost weight because your metabolism is running hot. And then you come off the medicines, your metabolism cools back down to where it always was, and you eat like you always did. And what happens when you do that? You gain your weight back plus 3 to 5%. So there we go again. The most effective approach for significant long-term weight loss in morbidly obese patients is surgery. Proven over and over. Not just lap bands, but all of the bariatric surgeries. And there are a number of available procedures. I'm going to show you some of them. The most common things on the market right now, of course, are lap bands and gastric bypass. And the fastest growing group of patients are opting for sleeve gastrectomies. And I'm going to show you what all of these are. There are other available options also, but they're much less common, and all of these have side effects to varying degrees. Okay, lap bands, and looking up here, you see the band is around the very top part of the stomach. The little catheter comes down and comes up to a little port that goes on under the skin, and we have a model down front that you can look at when we get done. Gastric bypass works by dividing the stomach right here, making this small pouch, dividing the small intestine way down here, pull that cut end of the intestine up and sew it to that pouch, and then hook the small intestine back together down here. We call that restrictive and malabsorptive. That means it restricts the amount of food that you eat to what that little pouch will hold. And it's malabsorptive, meaning that you bypass the stomach, the liver, the pancreas, and the first third to half of the small intestine, which is where everything is absorbed. Or if it's not absorbed there, it's broken down there. So when you have that, you're not breaking down what you eat, and you can't absorb what you do break down until it gets further down in the GI tract. So you do not have time to absorb it. That's how gastric bypass works. You eat, but you can't absorb it. And it restricts the amount that you can eat to that little pouch. There are complications that come from that. Sleeve gastrectomy, you take off about 80–85% of the stomach. The part of the stomach there in white is removed. So you take the stomach and change it from a larger reservoir or bag that you put food into a small narrow tube. You turn it into like a sleeve by taking out a large part of the stomach. Works very well. Does not have the same number of complications that gastric bypass has, but it also seems to not maybe last as long, doesn't work as well. At 4 to 5 years, a lot of these sleeve gastrectomy patients have started gaining the weight back because that tube dilates back up and becomes more of a pouch. Okay? How much do you expect to lose? How well do these things work? Okay? This particular study, at 4 years, you expect to lose, with gastric banding, with lap band, 45% plus or minus 20%, and with gastric bypass, 68% plus or minus 16%. So somewhere in the 25 to 65% at 4 years with lap band. How much is that? If you are that magic 100-pound overweight person and you're supposed to weigh 130 pounds and you weigh 230, you expect to lose 45 to 70 pounds, somewhere in that range. Okay? Now we're talking about significant weight loss. Instead of weighing 230, you can expect reasonably that you're going to be able to get down to 170, 175. And that's at 4 years. And we're not done at 4 years. We can keep losing. So, and I'll show you some pictures of people that have lost significantly more than that. Okay? My boss in Memphis, when I was training, used to say there was 3 kinds of lies. There was lies, there was damn lies, there was statistics. Okay? So you can make numbers say just about anything you want them to say. Move this out another year, and it goes up to 65% plus or minus 21%. So that takes lap band weight loss at 5 years from 45 to 85% excess body weight. If you're 200 pounds overweight, that means up to 170 pounds. That's pretty good. Sleeve gastrectomy is very similar in weight loss to gastric bypass. Okay? The complication rates, however, are very different. Total complications is anything from a minor stitch abscess, a minor little wound problem, to dying from the procedure, to having a lethal complication. Most of the complications that come from lap band are minor, but if you have a major complication, it can be life-threatening. That goes with any operation. If you come to the operating room to have a hangnail fixed and you're put to sleep and woke up and your hangnail is now repaired, you can have a complication from that operation that costs you your life. It is possible. It is not likely, but it is possible. The risk of these complications goes up with the other procedures. Okay? By a factor of about 10, by the way. The mortality rate, the chance that you're going to die of a complication from lap band is 0.05%. Okay? 1 in 2,000. The chance that you're going to die of a complication from gastric bypass, 0.5%. 1 in 200. So there's a 10-fold difference in mortality related to those two operations in particular. Sleeve gastrectomy is a little less than gastric bypass, but more than lap band. The reason it's less is you don't have to hook the intestine back together. Okay? When you compare all of these things, lap band is the safest procedure that's available to you. All right? Complications: band slippage, erosion, vomiting. A slip means that the band changes position. I'm going to grab my model. A slip means that some of the stomach can come up through the band and it makes too much tissue above the band. When that happens, that effectively makes the band tighter so that you have trouble swallowing. That has to be fixed, usually with another operation. It can be that we can reposition the band, we can fix the slip, put the band back on, save the band, no problem. It can be that you have to just cut the band off and quit. Doesn't mean that you can't have one again in the future. You can potentially. It's a little harder to do at that point. Erosion is where the band can rub a little hole in the wall of the stomach. It's also very uncommon. Okay? The company changed how we put these things in several years ago before I started doing them, so that we actually are putting more tissue in there than just what you see on the model. There's more stuff in there. And that helps to pad the stomach so that you don't have that same risk of slip and of erosion. If you have an erosion, the band has to come out. It doesn't mean that you can't have another one in the future, because you can potentially. But that band at that time has to be removed, because when it rubs that little hole, bacteria from in the stomach can get to the band. You cannot clean that up with antibiotics, and the band's got to come out. Okay? Okay. Gastric bypass. These complications are a little more worrisome. It's a bigger operation. You have a higher incidence of pulmonary emboli, or blood clots that go to the lungs, although you can have that with any of these. There's more problems with things leaking, where you have to hook the small intestine back together, you have to hook the small intestine to the stomach, and you have to divide the stomach into 2 pouches, and those lines where you've stapled that off have to heal. So if that leaks, that can be a life-threatening emergency. Also, when you do this, and on the little picture up here, you see that the little pouch is here, and then the rest of the stomach is here. Well, this is still functioning stomach. So if you develop a problem in that part of your stomach, we can't get to it. If you come in tonight to the emergency room and you're bleeding from an ulcer, I can take a scope and I can look down into your stomach, and I can probably stop that from bleeding with the scope. If you've had a gastric bypass, you can't get to it, because you come in with the scope down the esophagus into that little pouch and then down the intestine. You can't get to the rest of the stomach. So you lose that ability to do things with a scope, which can be a real problem. Vitamin and mineral deficiencies. We talked about your bypass in a large part of the small intestine where things are absorbed. In particular, things like iron and calcium, fat-soluble vitamins, etc. Those things have to go through your stomach and be treated with acid to make them where your body can absorb them. everybody with a gastric bypass gets what's called pernicious anemia. It means that you get anemic, your blood count goes down because you can't absorb iron. You have to take iron supplements. You have to take other vitamins and minerals, calcium, etc., forever. Or you can develop life-threatening deficiencies in those products because you can't absorb enough in your regular diet. Okay? 24% had at least one complication. Now again, most of the time that's a minor complication. But the incidence of major complications is significantly higher with these other procedures. Okay? Same thing really applies for sleeve gastrectomy. Again, it's not quite as bad as gastric bypass, but the complications are a lot more frequent than in lap band. Okay? Short hospital stay, pretty quickly getting back to work. This is all done with the laparoscope. The lap band, you have 5 small incisions. Each one you can cover with a regular sized Band-Aid. Most people go home the same day. Some people do spend the night. If we have any question whatsoever, we'll keep you overnight. Some insurance companies require you to spend the night. So it depends on the individual. Okay? But it's pretty common that people are going back to work a week later, 10 days later. As long as you don't do heavy lifting, manual labor, you can go back when you feel like it. Okay? Pluses and minuses, right? We said no free ride. Pluses and minuses come with everything. Gastric bypass, just real quickly, we'll hit this again. You lose weight very quickly. There's a rapid initial weight loss. It does not require anything be implanted. It does require that your stomach be stapled, cut, and the intestine rerouted and all hooked back together. Okay? Significantly higher complication rate, like we talked about. Mortality rate 0.5%. You can develop dumping syndrome, which is where the food that you do eat doesn't stay in that little pouch. It drops right down in the intestine. And folks, the solution to pollution is dilution, just like Dow Chemical. So when you dump stuff into the small intestine, the body sees that as too concentrated. And so it pours water in the intestine on top of it, and it's just like you flush a toilet. Down it goes. You get crampy abdominal pain, you get very flushed, have heart palpitations, break out in the sweat, and you better be close to the potty because here it comes. Okay? Dumping syndrome is not real pleasant. This is not adjustable. It's nigh on to impossible to reverse. You get what you get when you get it. When you come out of the operating room after your surgery, that's what you got. It's not adjustable at any point in the future. We talked about vitamin deficiencies, a little longer in the hospital and a little bit longer get over it time and higher complications. Okay? Sleeve gastrectomy, I'm not going to go through this as much. It is available. If someone is interested in sleeve gastrectomy, I have a friend up in LaGrange who does a good number of them, and he is available. We can hook you up with him. This is not a bad operation. I think it's a better operation than gastric bypass. But you have to stay on top of what you're eating because you will tend to gain your weight back 4 to 5 years after surgery. Okay? Again, it is not adjustable and not reversible. Part of your stomach is gone. It's in a bucket somewhere. Okay, lap band. There is no stapling of the stomach. There is no reconnecting of the intestine. Okay, we don't have to divide or cut or reroute anything. We are shooting to maintain a steady, slower, and I think more healthy weight loss. Y'all heard about the tortoise and the hare when you were growing up, right? I really do think slow and steady wins the race. That we're not shooting for 5 pounds a week. We're shooting for 1 pound to 1.5 pounds a week. And I have people roll their eyes when I say that, but if you stop and think about it, 1.5 pounds a week is 75 pounds a year. In 2 years, that's 150 pounds. Folks, that's a lot of pounds. That's losing a significant amount of weight. Okay? So, a slower, healthier weight loss. There is no dumping syndrome. It is adjustable, customizable to you. So if you are not filling up quickly, if you feel hungry between meals, if you're not losing weight, if you're not satisfied with a small meal, we can tighten the band up very, very easily. It's done in the office, takes about 3 minutes, and generally speaking, it's not hard to do and something that can be done very quickly. So you come in and we talk about it, okay? Now notice what I just said. You have to come in and we talk about it. Whether you're seeing me or your primary care doctor who's trained in lap band management, makes no difference. You have to see someone and you have to talk about the band and how you're doing with it. And you go through those things that I just mentioned. And if you need an adjustment, we put a little saline in. And then we're going to come back in a month and we're going to see how we did. And if you're losing weight, and if you're satisfied with a small meal, you have good portion control. And if you're not hungry between meals, then we're going to ride that one for another month or 2 months or 3 months. But then you're going to have to come back because we're looking for that sweet spot on the band. Everybody's different. Okay? There are little variations in how much tissue is in there and how thick the stomach is. And so everybody's different. Some people are tight when they have 4 cc's in a band. Some people need 11 cc's in their band. So everybody's different. The number in the band, the volume in the band is not important. We're going for the effect. Okay? I have people all the time that say, well, Susie's up to 6.5 cc's and I've only got 6, so I want another half cc in my band. No, that's not how it works. We go for effect with you. It's personalized for you. If we're not to the sweet spot yet, we will keep bumping it until we get there. Okay? This does not mean come in the office, hey, Dr. Melton, I'm going on a cruise next week. Let's loosen this puppy up. Going to hit the buffet on the boat. No, that ain't how that works. Hey, my granddaughter's getting married. We're going to have a real nice shindig. I want to be... No, that's not how that works. Okay? However, if you're having an operation or you need to have an endoscopy or something else where we need to loosen the band, we'll suck all the saline out of it. You can come back the next day and we can start putting it back in. So it is adjustable, customized to you for effect. Okay? That's the only one of these procedures that is like that. We talked about the complication rate, the mortality rate, outpatient as opposed to inpatient procedures. Disadvantages. And again, is that really a disadvantage, a gradual, long-term, slow, healthier weight loss? Is that a disadvantage? I don't think so. I don't think so. It is an implanted medical device. It's medical grade silicone and stainless steel. It's not going anywhere. It is not reactive. Your body does not reject it. It is a mechanical device. It can get infected, although that's uncommon. If it gets infected, it generally has to be removed. But that's a rare problem. Okay? It is performed laparoscopically. We'll show you a short video. We put it right up here, put the band in and connect it, attach it to the port, put the port right up under the skin. We can put a needle directly into it and blow the band up, make it tighter. The idea is that we restrict the amount of food that you can get to go through the band into the stomach. Okay? There's a plan. We make a small pouch. That little pouch, we used to think you filled up with a small meal and let it slowly go through the band. That actually may not be correct. I've been telling people that for 3.5 years. But there is new data from a surgeon named Paul O'Brien in Australia. I say new, it's been out since about November. That shows it probably doesn't work that way. How this thing actually works is you get the band in the right position, high on the stomach, but there's a little pouch above it of stomach and then esophagus above that. You take a bite, you chew like crazy, small bite, chew like crazy. It goes down your esophagus and it hits the band. comes down your esophagus and hits the band. When it hits the band, it stops. That little pouch of stomach and then esophagus above that has the ability to squeeze extra hard. And it starts milking it, just like a snake swallowing a mouse. Okay? And it squeezes, squeezes, squeezes until it squeezes that little bolus of food through the band down into your stomach. When it does that, that extra pressure that it generates fires nerve endings that go up into your brain to a place that we call the satiety center. Satiety is that feeling at the end of a meal when you're no longer hungry. When you say, okay, I'm good, I can quit. That is satiety. Once that set of nerves has fired 15 to 20 times, most people, if they are eating slowly enough, are able to recognize the fact that they're no longer hungry. It doesn't mean that you're stuffed, that you're full like a Christmas turkey. It means that you're not hungry anymore. Okay? So you have to eat slowly. You have to take a small bite, chew, swallow, sit there for 60 seconds. Everybody listen to that part. That's tough. Sit there for 60 seconds and then take another bite. In that 60 seconds, that little pouch has time to empty and push that food through. Those nerves fire in your brain, and 15 to 20 bites into that meal, you should feel that you're no longer hungry. Now, everybody in this room knows somebody that's thin that eats like that, right? My wife, that's how she eats. Every meal, always have. She's little bitty. That's how she eats. That's how we're supposed to eat, folks. It's just us big folks, we don't do that. We like to get it in and get it down. Okay? So you have to work on changing how you eat when you have a band. Also, if you eat too quickly, if you don't give it time to get that food bolus through there, if you don't chew well, if you take too big a bite, it's going to hurt. Okay? So the band will spank you if you misbehave. And you may get something stuck and have to throw up. Not pleasant. Okay? Most of my band patients, I don't have a band so I don't know, but most of my band patients tell me that it's an unpleasant feeling when something gets stuck there and won't go through. They don't like that. They don't do that very often. Okay? All right. We'll move on. One more quick summary. Doesn't require any stapling, gradual healthy weight loss, long-term weight loss. In 5 years, you expect to lose 64% plus or minus 21% excess body weight. So 45 to 85% of your excess body weight. If you're 100 pounds overweight, that's up to 85 pounds of it gone. That is meaningful weight loss. Okay? That's life-changing, life-saving weight loss. Why the lap band? We talked about those results, right? This is just another slide showing it showing the same thing. That when you get up to 2 years, 3 years, 5 years out, then you've lost a significant amount of weight. Okay? And when you compare it to gastric bypass and sleeve gastrectomy, at 4 and 5 years, the weight loss curves come together, and it's essentially the same thing. There's no statistically significant difference in the weight loss between those three procedures 4 and 5 years out. Because gastric bypass and sleeve gastrectomy patients lose weight more quickly, but then they tend to plateau and then start gaining the weight back. So you wind up at the same weight loss 5 years down the road, but you've done it with 1/10 the risk of significant complications. That is why we do lap bands instead of gastric bypass. You lose the same amount of weight, but you do it with 1/10 the mortality, the 1/10 the chance that you're going to die of a complication. That's why we do lap bands. Okay? Again, this just showing you that it keeps on working. This is a lifelong commitment, folks. We don't do this and lose weight and then take the band out. All right? The bands that were put in 17 years ago are still functional. They don't degrade. They're fine right where they are. We want you to lose weight, get to your goal weight, and then we'll loosen the band up so that you quit losing weight. I have several patients now that we have tried to quit losing weight. Okay? It's time for them to quit. They've reached their goal weight. They're as low as they want to go. And so we loosen the band. And the idea, and people get really scared when you start loosening their band. No, I don't want to gain my weight back. No, I don't want, no. We loosen the weight, loosen the band just a little bit, and we want your weight to stabilize. And then if it starts to creep back up, we can tighten the band back up. Okay? It's adjustable. All you have to do is have somebody that can take care of your band, and you can use it from now on. You've all also probably talked to someone who has a lap band and they hadn't lost a whole lot of weight. Most of the time, those are people that have gotten a lap band and not done the follow-up. They quit going. They quit going to the doctors. That's why it fails. You've got to come. You've got to come sit in the office and talk about what you're eating, how much you're eating, how it's affecting you, how do you feel, how is this thing working, are we losing weight, are we not losing weight, are you full between meals, all of those things we've been talking about. When you do that, we can adjust that band and we can get the most out of it. If you don't come, it can't be adjusted. It has to be adjusted to be successful. So each one of you will talk to someone who's gone off to Timbuktu and had a band put in on the cheap, and they've never had follow-up, they've never seen anybody, or they've seen someone very rarely, and they haven't lost any weight. I see it frequently. Okay? You have to come for follow-up. What does it do when you lose this weight? Well, ladies, if you've had trouble getting pregnant, I got a surprise. Or you may get a surprise, better way to put it. When you're overweight, estrogen is stored in fat cells and is kind of released in a haphazard manner. So you don't ovulate properly. So it can be difficult to get pregnant. When you lose that weight, you tend to free up that excess estrogen, and then you just work off the estrogen that you make every month in your ovaries like you're supposed to. And then you ovulate properly and you can wind up pregnant. We want everyone of childbearing age to use some form of birth control for at least the first year. And then if you want to get pregnant, fine, have at it. And we can work with your OBGYN to make sure that the baby gains weight properly. That doesn't mean you have to gain weight. It means the baby has to gain weight. And so if the baby is gaining weight and growing properly, then we'll adjust the band as needed to help you do that. You can expect improved physical abilities, because when you're overweight, we talked about how you just give out when you go to the gym and you can't keep going back. Well, if you get that excess weight off so that you're not beating your hips and knees and ankles to death, you can do more. Okay? It's a self-fulfilling prophecy. You really do get the snowball rolling downhill, and it gains momentum. As you lose weight, your ability to do these things improves. As your ability to do these things improves, it helps you with losing more weight, and it grows like that. Okay? Improved quality of life. That's pretty subjective. That's what you think it does. Okay? But 90% of patients say that it improves their quality of life. Body image, depression, reflux, high blood pressure, diabetes, sleep apnea. You don't have to wear that, fighter pilot mask, all of that stuff. All of those things are directly related to obesity, and when you get that weight off, those things all get better, and most of them go away completely. Okay, this is one of my favorite slides, and it is a little small, and it's kind of busy, but if you look up there, you see all these big numbers and the word resolved, 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 meaning that a large percentage of these things go away completely. Heart disease, 82% risk reduction. Heart disease, 82%. Asthma, 82% improved or resolved. Okay. Okay? Sleep apnea, up to 98% resolved, meaning they don't have it anymore. This slide is also wrong. Over on the left-hand side, it says type 2 diabetes, 83%. That's not correct. It's actually 93%. 93% of type 2 diabetics who have any of these bariatric surgeries and lose a significant amount of weight are no longer diabetic. It means your hemoglobin A1C goes to normal. You don't have to stick your finger. You don't have to take insulin or pills. You're not on special food. You're not diabetic anymore. That is an amazing statistic, because diabetes can kill you, can take your eyes, your kidneys, your legs, your heart, brain, etc. Horrible disease. Up to 93% are gone. Okay? Quality of life improved in 95%, and mortality 89% reduction in 5 years. What does that mean? That means if you take a large group of patients and half of them have bariatric surgery and half of them don't, and you see who dies and who doesn't, the group that has surgery is almost 90% less likely to die in the next 5 years. That means that this works, folks. Not only are we making people prettier, even though that is not our goal, we're making people healthier, and we're making people live longer. Okay? Very, very important. That's why we do it. I'm not out here to make a swimsuit cover model for Sports Illustrated. All right? That's not what I'm doing this for. But we can take somebody who may have 10 years to live and change that to 25 years to live. That's why we're doing it. Okay? All right. Again, just shows that this works to get rid of diabetes. Why should you choose lap band? And the lap band AP system, that means advanced platform. That is the newest one. It's been out about 4 years now, and that's the one we use. Well, proven safe, much lower complication rate. You can expect to lose a significant amount of excess body weight. It's quality weight loss, meaning that when you lose it slowly, you aren't burning up muscle, you aren't degrading proteins, you're burning fat, and you're able to maintain the good stuff. If you start burning up muscle, there's other things that are very important that are muscles, like heart tissue, that are affected. So losing weight too quickly is a bad problem. It's sustainable. We can lose weight as long as we keep working this band. Now, I've seen people, matter of fact, when I started doing this procedure, I had to have a proctor come in. I had to prove that I did advanced laparoscopic surgery, a bunch of it, and I had to go do all the coursework. And then I had a proctor come in here to do my first day of cases with me, and I had to do a minimum of 2 as required by the FDA. Well, we had this guy here from Tampa, and let's don't do 2, let's do 4, let's pick his brain. So we did 4 the first day. And then he has to sign off, yes, he's okay to do the procedure before we could even start buying the stuff. My point is, he had a band put in 6 years prior to that, and he had lost 170 pounds. He was still not skinny, but he had lost a ton of weight. And he said his band had been empty for 2 years. He had nothing in it. But having the band there and eating the way he had learned to eat, he was able to maintain his weight where he was, and he was happy at that goal weight. And he was also much healthier. He was off of his diabetes medicines, his blood pressure medicines, his sleep apnea stuff, his cholesterol was normal. Everything had reverted back to normal, and he had been with an empty band for 2 years. Okay? That's why we do it. It's sustainable. Okay. Patient satisfaction, we talked about. Who's a candidate for lap band? If you are at least 18 years of age, your BMI is above 30, or it may be a 35 requirement based on your insurance, somewhere in that range. Or if you have a BMI of 40 and you don't have any health problems, if you've tried to lose weight and have been unsuccessful, if you don't have a a definable disease that makes you overweight, and these are rare, regardless of what people think about, well, I've got a bad thyroid, it's why I'm up. No, you're probably overweight because you like hamburgers and french fries instead of because you're hypothyroid. It's very uncommon for that to be causing significant weight gain. You're willing to use this properly. You're willing to make a lifelong adjustment and use this device like it's intended and come for follow-up, then you're a candidate. Okay? That's who we're offering this procedure to. Show you a few people. And the first ones are not my patients. They're provided by the company. I will show you some of our patients here in a minute. Michelle, I didn't have the energy to take my kids to parks, and I was embarrassed because I couldn't fit in the go-kart and the roller coaster. That sound familiar to anybody? There's the before. There's the after. Now, notice, Michelle is not petite. She's not skinny. She doesn't look like a refugee. She's not going to be a swimsuit model. But that looks like a different woman. Okay? Here's Michael. Michael and Michelle. I didn't notice that until just then. Michelle and Michael. Anyway. Unhealthy every day. Diabetic. Tired of living like that. That's what he looks like now. That's with a lap band. Okay? Tried everything. Now it looks like that. Very different person, huh? Wendy couldn't play softball. Now, she's not skinny. She's very attractive, but she's not skinny. She's not going to be on a runway somewhere. But that is a much healthier lady. Okay? This is mine. This is Heather. November of 2010. And I asked her, I said, Heather, is your husband going to do this? No, he's going to take care of it himself. He says he can do it himself. Well, I'm going to tell you, Heather's husband still looks like that. And Heather looks like that. Now, she has lost 141 pounds. She now weighs 125 pounds. She's 5'3". Okay? She has lost more weight than she currently weighs. That's a different woman. Different woman. One more time. There's Heather. There's half a Heather. Okay? Yeah, it's a big difference. Big difference. Losing excess fat and preserving necessary tissue. Weight loss is not all the same. Again, we want to do this gradually. It's more healthy. It's much more similar to doing quote-unquote diet and exercise. I promise I'll quit using that D word. We lose the excess fat, but we want to keep the good stuff. We want muscle and bone and tendon and everything else to stay fully functional and to be strong. So we do it more gradually. Okay? You lose a lot of excess fat, but you also lose all this other stuff, and the type of surgery you have has a lifelong impact on your health. We saw a lady last December that had a gastric bypass, came in our hospital and died. She had the bypass somewhere else, came in our hospital severely malnourished and had to have surgery because of it and just could not tolerate the surgery. Okay, and this was 3 years after her bypass. It can be a real problem. That's enough about that. The most advanced, redesigned, newest, latest, greatest band is the one that we do. It's by the company called Allergan. You can look them up online and research it. We use the AP system band. It comes in two sizes, a standard and a large. We pick the one that fits you the best when we're in the operating room. We don't know which one it's going to be. Some folks that I think are going to take a standard band wind up with a large and the other way around. Okay? There have been a ton of these things sold, literally. The way this thing is designed, and we have one right here that we'll pass around, it almost looks like little pillows on the inside of the band. Okay, and this thing just unlocks and comes apart. Okay, but then this port is not on there. You take the catheter, put it through the locking mechanism, tighten it up around the stomach, and lock it, and it doesn't come open. Okay, but that little pillow design keeps the thing from crimping. If you take a long tube, fill it up with air, and then turn it into a circle, it usually crimps into 3 pieces. It crimps into a triangle. That's what happens with the old Allergan bands, and that's what happens with the brand new Ethicon band. That's what they do. That gives you a crimp point or a fail point, and those are bands that have a tendency to not last forever. They can be problems. And this is the type of port that we use now. It's called an easy port. It's a little different from the one on the other model. This one is a little flatter. It's also a little wider at the top. I also put my ports right there. Okay? Over in Albany, for example, they put them up here. I don't like that. A couple of reasons. And I've told them I don't like that. They say, we don't care, that's what we're going to do anyway. But they put them up here because it's easy to access. It's thinner up here. There's less fat. It's much easier to feel or see. And a nurse or a PA can feel that and stick it very easily. You put it down here, there's a little bit more to hide it. It's usually thicker down to where it's attached, and it's a little harder to stick. Well, I don't care. I don't have any problem doing it. I can find it. I'm sticking them, or another doctor in town is trained to do it, is sticking it. It's not being stuck by a PA or a nurse, and it is a little harder to stick, but it hides better. Where do you ladies lose weight the fastest when you lose weight? Right here. This is it's the first place you lose it in the what's it called, the décolleté. Your collarbone starts to stick out a little bit. Well, if you've got an incision right over here with a port under the skin, pretty soon you're losing weight and you're feeling sexy. You want to go out juking and you're putting on something maybe cut low or strapless, and next thing you know, you got a port sticking out up here with a scar over it, and it's visible. Well, if you need to have chemotherapy, that's a wonderful thing. But if you're doing this for weight reduction, I don't really see where that's necessary. So I like mine down here. They're out of the way. They're not a problem. Okay, so that's where they go. What does it cost? Well, we talked about what medicines cost, and y'all can pass that around if you like. We talked about what medicines cost. You can easily spend $1,000 a month on medicines, right? Going to your doctor, every time you go, you have a copay, or you've got your deductible. Anybody's deductible gone down over the last 3 years? Raise your hand. Raise your hand. Where are you? Nobody?
I want that insurance.
Yeah, nobody. Of course not nobody. Everybody's deductible is going up. I know one of our largest employers in town recently went to a $5,000 deductible. Okay? Folks, that's tough duty. So if you have to pay that every year, it adds up real quick. Anytime you go for lab work, or if you have to go to the cardiologist or the gastroenterologist or whoever, us big folks that like to eat a lot, we like to eat good food, and you pay more. If you eat more, it costs more, right? Co-pays for physical therapists, etc., prescriptions, inactivity costs. And when we're inactive, we're not really inactive, are we? We're doing something else. We're sitting at the house, we're watching cable, or we're renting movies, or we're playing video games, and those aren't free. We go into the movie theater, or we go out to eat, or whatever it is we're doing. We call it inactivity, but we're not really inactive, and we're paying for the privilege. Okay? So all of those things cost money. going to Weight Watchers, Curves, Physician Weight Loss, or the Y, they charge you to do that, right? It's not free. A very good thing, our YMCA is very helpful to us and to you. They know that obesity is a problem. They are committed to helping you take care of the problem. If you start going to the support groups and you sign up at the Y and you buy a 6-month membership and you attend their weigh-ins and work with their personal trainer, then at the end of 6 months, if you've met your goal of coming X number of times a week, then you get 6 months for free. Now folks, that's a pretty good deal. If you pay for 6 months and use it, and they'll give you 6 months for free. All right? Our YMCA, and I applaud them, are doing a really good job of helping us, partnering with us to help our bariatric patients get better. And if you want to set up a bariatric patient exercise group, they'll do that. If you want to do water aerobics because you got bad knees, done. You want to set up a bariatric step class so that you can get several other people in there that are the same basic size, and you don't have to stand there next to a couple of size 4s and leotards, then you're more likely to go and keep going, right? I mean, who wants to get in there with a size 4 when you're 24? No, I get it. But they do too, and they will help you set up those classes, okay? The point here is that these costs add up, and losing a significant amount of weight, dramatic weight loss, greatly reduces these costs. Okay? Is it covered by your insurance? I don't know. You tell me. If you don't know, on your insurance card, if you have one, there's an 800 number on the back. Call them and ask them, does my plan cover lap band? They'll tell you. If they say, yeah, if you meet certain criteria, well, that's great, because we can work with that. If they say, no, it's not covered, well, they're not going to change their minds. We can write letters till we're blue in the face, and they're not going to change their minds. But that's okay. We got other options for that, too. If we apply and they deny it, then learn what the appeal process is. They gave you a book when you signed up with your insurance plan. If you don't have it, call them. They'll send you another one if you want to read it yourself, or just call that 800 number and ask them. You can also call the Bariatric Center, and Ashley will help you with it. She'll call them and talk to them for you. All we need is your insurance information. Before you leave tonight, Nicole and Ashley can take a picture of your insurance card with a smartphone, and they can contact insurance companies for you and find out if it's covered. Okay? You can also call or go online to lapband.com. Everybody have internet access? Yes? If you don't, it's time to join us in the 21st century, folks. There's too much information out there. Get internet access somewhere. You don't have to pay for it at home. You can go to the library and do it. Or talk to a friend of yours and use their computer one night. Because we'll also use it as part of your informed consent before surgery. Because we'll give you a couple of things to do on the internet. Okay? Some of this can even be financed through medical financing companies. This is one of them. There are others out there. If you need that option, search them online. Use lapband.com. They have what is called My Lap Band Journey, my personal journey. It's free. You don't have to have a lap band to use it. You can sign up for it tonight. You can put your pictures on it. You can track your progress, track your weight. You can look up all kinds of helpful tips. There's a set of questions in there for you, a checklist, the I'm Ready checklist. So once you've gone through that checklist, it's telling you that you have a reasonable amount of information. Sometimes people get frozen trying to get more information. Okay? So this helps you, it prompts you, yes, I've got enough information, let's move on. Okay? So look at that. It can be very helpful. Go to lapband.com and you can look at all of these things, okay? You can personalize it as much as you want, pre-op, post-op. It tells you about what to expect. It lets you track your weight. It tells you what the risks are related to obesity. We will hook you up when you come to see us with Lapband Emmy so that you get more information. There's going to be a lot of repetition. What you hear here, you'll read in a book, and you'll look at Lapband Emmy, and you'll hear again when you come to the office, and there's a lot of repetition here because the more likely you are to retain it comes from hearing it over and over. Okay? All right, look for profiles. You can set up your own profile. You can make a movie. There's a new mobile app. It's called Lapband Mobile, strangely enough. And it'll do all kinds of things. It's free. If you have an iPhone or an Android, it's available for both, that it's free. You can download it tonight. There's a real neat thing in there called the Transform-Me, like transform with a me on the end of it. And you take your picture, and then you can, the computer will shrink you down to show you what you look like as you lose weight. It's pretty cool. There's a reading list of things for you to go through online that's very helpful. Again, the more information you have, the better you're going to do. I don't want somebody to come in my office 3 months after surgery and say, I didn't know I might have trouble eating shrimp. Some people have trouble eating shrimp. Shrimp can be very fibrous, or lobster, or tough meats. Everybody's different. Most people don't have any trouble. You ought to be able to eat just about anything if you chew it properly, okay? But the more information you have, the better you're going to do. When you come to the office, we're going to go through that list of questions, and we want to get you in the green zone. You saw that poster page earlier. We want to make sure that you're losing weight, you're satisfied with a small meal, that you have good portion control, and that you're not hungry between meals. And if that's the case, then you're in the green, and we just keep going like we're going. If you're not doing those things, then we need to put some more in. If it's too tight and you're having vomiting problems, throwing up, too much reflux, things aren't going down well, then we take a little out. Okay? When you have it, you'll get a card, and you can even wear bracelets or necklaces. Most people don't, but you'll have all that stuff available if you want to do it. We have a support group. You're welcome to go before you have a band. It meets the second Monday at the Y at 5:30. Go in the front door of our local YMCA, turn right down the hall, and they're down there in the big room. If they move it somewhere else, they'll put a sign up. Okay? The second Monday of each month, which I believe is the 13th next month. Is that right, Ashley? 5:30 at the Y. You're welcome to go. They will answer questions for you. Okay? Okay. All kind of stuff online like we talked about. When you go through the procedure, we are all here for you. We will support you and motivate you and remind you and all of that. Okay? We go through this over and over and over and over. Because again, the more times you hear it, the more likely it is to sink in. Okay? All right. Do we need to go through this again? We know it's a problem. We're looking for something that's gradual and healthy, maintainable, sustainable. And we're going to help you through it when we get to it. The last thing I'll tell you is, how do you eat afterwards? You will be on a diet for 2 weeks before the surgery. Okay? There's the D word for the last time. It should hopefully be the last diet you ever go on. But when you come for your nutritional evaluation or dietary evaluation at the hospital, they will give you a copy of a diet. It is a protein-sparing fasting type of diet. It's pretty significant. The reason we do that is when you have fatty behind, you have usually fatty liver also. And we want your liver to shrink up. So when you go on a significant diet like this, that is protein mostly, no carbohydrate, no fat, you burn glycogen stores in your liver, and your liver visibly shrinks up. So it gets out of the way. It's safer to do the surgery. It's easier for me to lift it up, go up under the liver, and put the band on where it belongs. Okay? So you will go on a diet for 2 weeks prior to the surgery. When you come in to have the surgery, we do the procedure. You'll have a barium swallow afterwards where you drink a little barium, we watch it go down, make sure everything looks okay. You can usually go home shortly thereafter or the next morning, and you'll be on clear liquids for 1 week. Clear liquids means the consistency of water. It doesn't have to be clear. Okay? Water, tea, coffee, Crystal Light, Jell-O with no fruit in it, sugar-free popsicles, etc. You'll do that for 1 week. Then you'll come back to the office, we'll take your staples out, make sure everything's going okay, and then you go to full liquids for 10 days. 10 days, full liquids. That is milkshake consistency. You can do protein milkshakes. You can do Boost or Carnation Instant Breakfast or Slim Fast. You can take any can of soup and put it in a blender and turn it into a milkshake consistency and drink it for 10 days. And then you will have 10 days of pureed foods, baby food consistency. Take pasta or fish and mash it up with a fork. Or some people eat baby food. I can't imagine doing that, but okay, whatever. You can take a hamburger patty and put it in a food processor and just hit it once and chop it into real fine pieces and eat that. Okay? That's for 10 days. That gets us to 4 weeks after the surgery, and at that point, you're usually ready for your first adjustment, and you're ready to go to knife and fork foods. Okay? That's how we do it. So, I hope you have learned something. Okay? We've covered a lot of material. Go look at it again because it's too much material to sink in. Go to lapband.com. Go to My Lapband Personal Journey. Call us. Call the Bariatric Center. Talk to Ashley and Nicole. Call my office. Get set up for a nutritional evaluation and a psychological evaluation, which everyone has to do. When you complete those things, they'll get you an appointment to come in and talk to me, and they'll be working on your insurance already, and then we'll get moving with getting the surgery done. Some insurances require medically supervised weight loss anywhere from 3 months to 6 months. Some insurances are really hard to deal with. Some are not. Cash is easy. We have a cash option that you saw on the TV commercial. It's $10,000. That covers me, the hospital, and anesthesia. It does not cover pre-op visits. It does not cover if you need something extra, like if you need to go see a cardiologist or a pulmonologist or something like that. Most of the time, all your pre-op stuff is covered by insurance. Even though they may not cover the surgery, they'll cover office visits for things. Okay? So all of these things are things that we can help you work through. All you have to do is get in touch with us. Okay? I hope you learned something. Call us at the Bariatric Center at 890-3414. One more time, if everybody's got a pen, 229-890-3414. Thank you.